Welcome to our Pleural Effusion review. In this video, we will master the pathophysiology of transidates and exudates, Light's criteria, pleural fluid analysis, how to distinguish parapneumonic effusions from empyema, and the special types including hemothorax and chylothorax. Let's get started. A pleural effusion is an abnormal accumulation of fluid in the pleural space. There are two fundamental mechanisms that guide the entire workup. A transidate results from a systemic imbalance in pressures. Elevated hydrostatic pressure or reduced oncotic pressure pushes fluid across an intact pleural membrane. The fluid is low in protein and typically clear. An exudate results from increased capillary permeability due to local pleural inflammation or injury. The fluid is protein-rich and often cloudy. Step 2, Pearl. Think of transidates as a pressure problem and exudates as a leaky pleura problem. Light's criteria is the tool we use to separate them. Transudative effusions come from systemic conditions that alter pressures across an intact pleura. The number one cause is congestive heart failure. Other important causes include hepatic cirrhosis, which produces effusions through hypoalbuminemia, and hepatic hydrothorax, when acidic fluid moves through diaphragmatic defects. Nephrotic syndrome causes effusion through massive protein loss and low oncotic pressure. Chronic kidney disease can cause volume overload with sodium retention, and protein-losing enteropathy can drop albumin enough to cause an effusion. Step 2, Pearl. Congestive heart failure is the number one cause of transudative effusion. These are typically bilateral, with the right side larger than the left. Exudative effusions come from local pleural disease that increases capillary permeability. The major categories are infection, including parapneumonic effusion, empyema, and tuberculosis. Malignancy, including lung cancer, mesothelioma, and metastases from breast, ovarian, and other cancers. Inflammatory causes such as pancreatitis, systemic lupus erythematosus, and rheumatoid arthritis, and other causes including pulmonary embolism, hemothorax, and chylothorax. Step 2, Pearl. Pulmonary embolism is unique because it can cause either a transidate or an exudate. So don't rule out PE just because the fluid is transudative. Clinically, patients present with dyspnea, which is the most common symptom, pleuritic chest pain that worsens with inspiration, and a dry, non-productive cough. Symptoms of the underlying disease, such as fever from infection or weight loss from malignancy, are also often present. On physical exam, the classic triad is dullness to percussion, decreased tactile fremitus, and decreased or absent breath sounds over the effusion. A pleural friction rub may be heard, and there may be asymmetric chest expansion in large effusions. Step 2, Pearl. Memorize the classic triad. Dullness plus decreased fremitus plus decreased breath sounds means pleural effusion. Compared to pneumonia, which gives dullness plus increased fremitus. Chest X-ray is the first-line imaging study. Findings include blunting of the costophrenic angle, the meniscus sign showing a concave upper margin of fluid, and mediastinal shift in large effusions. A chest X-ray can detect effusions greater than about 200 milliliters. Ultrasound is highly sensitive and can detect as little as 20 milliliters of fluid. It is also the preferred modality to guide thoracentesis. CT chest is the gold standard for characterizing the cause. It can detect small effusions, loculations, and the split pleura sign, which suggests empyema. Step 2, Pearl. A lateral decubitus X-ray helps detect small effusions and can confirm whether fluid is free-flowing, meaning it layers with position change, or loculated, meaning it stays fixed. Light's criteria distinguishes exudates from transidates and is the single most important tool in pleural effusion workup. The criteria. If any one of the three is met, the fluid is an exudate. First, the pleural fluid to serum protein ratio is greater than 0.5. Second, the pleural fluid to serum LDH ratio is greater than 0.6. Third, the pleural fluid LDH is greater than 2/3 of the upper limit of normal serum LDH. If none of these criteria are met, the fluid is a transidate. Step 2, Pearl. A very high pleural fluid LDH, above 1,000, points to empyema, malignancy, or rheumatoid effusion. Beyond Light's criteria, several adjunctive tests narrow the diagnosis. Low glucose, below 60, is remembered with the mnemonic MEET. Malignancy, empyema, arthritis meaning rheumatoid, and tuberculosis. Low pH, below 7.2, indicates a complicated parapneumonic effusion. Empyema, malignant effusion, or esophageal perforation. Cell count differentials help. Neutrophil predominance greater than 50% suggests acute bacterial infection. Lymphocyte predominance greater than 50% suggests tuberculosis or malignancy. Red blood cells greater than 5,000 suggest pneumothorax. Pulmonary embolism or cancer. Special markers include adenosine deaminase or ADA greater than 50, which strongly suggests tuberculosis. Amylase greater than 200 suggests pancreatitis or esophageal rupture. Rheumatoid factor and AA suggests collagen vascular disease. Step 2 Pleural. Lymphocyte predominant effusion with elevated ADA is classic for tuberculous pleurisy. Parapneumonic effusion progresses through 3 stages. Uncomplicated parapneumonic effusion is an exudate without bacterial invasion. The pH is above 7.2. Glucose is normal or slightly low, and gram stain is negative. Treatment is antibiotics alone. Empyema is frank pus in the pleural space from bacterial invasion. The pH is below 7.2. Glucose is below 60, and gram stain is positive. On CT, you see the split pleura sign. Treatment requires antibiotics plus chest tube drainage. Complicated parapneumonic effusion is the intermediate stage. There's bacterial invasion, but no frank pus. It still requires drainage to prevent progression to empyema. Step 2 Pleural. If a pneumonia patient is not improving on antibiotics, get imaging to rule out empyema. Drain if pH is below 7.2, glucose is below 60, or gram stain is positive. There are 3 special types of effusion to distinguish. Hemothorax is blood in the pleural space, defined as pleural fluid hematocrit greater than half the peripheral hematocrit, or red blood cells greater than 5,000. Causes include trauma and malignancy. Always drain a hemothorax to prevent clot organization. Chylothorax is milky fluid with triglycerides greater than 110 and cholesterol less than 200. Chylomicrons are present. The cause is thoracic duct injury, most commonly from lymphoma or thoracic surgery. Pseudochylothorax also appears milky, but has cholesterol greater than 200, triglycerides less than 110, and cholesterol crystals in the fluid. It results from chronic effusion, classically in tuberculosis or rheumatoid arthritis. Malignant effusion is typically exudative with pH below 7.2, high LDH, and positive cytology. Lung cancer and breast cancer are the most common causes. Step 2 Pleural. For milky fluid, check triglycerides first. High triglycerides mean chylothorax. Cholesterol crystals mean pseudochylothorax. Management depends on the underlying cause. For transudative effusions, treat the underlying cause. Diuretics for congestive heart failure. Albumin for cirrhosis with hypoalbuminemia. Therapeutic thoracentesis is done only if the patient is symptomatic. For empyema or complicated parapneumonic effusion, give antibiotics plus chest tube drainage. If the effusion is loculated, consider intrapleural fibrinolytics, such as tissue plasminogen activator combined with DNAase, or video-assisted thoracoscopic surgery. For malignant effusion, therapeutic thoracentesis for symptom relief, with pleurodesis using talc, or an indwelling pleural catheter for recurrent effusions. For hemothorax, place a large bore chest tube immediately to prevent clot organization. Step 2 Pleural. Never remove more than 1 to 1.5 liters of fluid at a single thoracentesis. Draining too much too fast risks re-expansion pulmonary edema, which can be life-threatening. Let's wrap up. Causes. The number 1 transudative cause is congestive heart failure, followed by cirrhosis and nephrotic syndrome. Exudative causes include pneumonia, malignancy, tuberculosis, pulmonary embolism, and pancreatitis. Clinical. Dyspnea, pleuritic chest pain, and the classic exam triad of dullness plus decreased fremitus plus decreased breath sounds. Imaging. Chest X-ray shows blunted costophrenic angle and meniscus sign. Lights criteria. Any one of the 3 makes it an exudate. Protein ratio greater than 0.5. LDH ratio greater than 0.6, or LDH greater than 2/3 of the upper limit of normal. Fluid analysis. Meet mnemonic for low glucose. Malignancy. Empyema. Arthritis. Tuberculosis. Lymphocytic effusion with elevated ADA suggests tuberculosis. Fish below 7.2 means empyema. Special types. Hemothorax has hematocrit greater than half the peripheral value. Chylothorax has triglycerides above 110. Pseudochylothorax has cholesterol crystals. Management. Treat the underlying cause for transidates. Antibiotics plus chest tube for empyema. Pleurodesis for recurrent malignant effusion. Chest tube always for hemothorax. Finally, the classic step 2 traps. Any single Light's criterion met makes it an exudate. Empyema always needs a chest tube. Hemothorax must be drained to prevent clot organization. And never remove more than 1 to 1.5 liters at one time to avoid re-expansion pulmonary edema. Good luck on your exam.